Yesterday, the emergency committee met for the 15th time and recommended to me that I declare an end to the public health emergency of international concern. I have accepted that advice. It's therefore with great hope that I declare COVID-19 over as a global health emergency.
On May 5th, the World Health Organization announced an end to the emergency declaration for COVID-19. The announcement came more than 3 years after the health body had declared the virus an emergency of global concern on January 30th, 2020. Back then, there were fewer than 10,000 infections, and most of them were centered in China. Welcome to Issues and Insiders. In line with the announcement by the global health body to officially end the emergency status for COVID-19 earlier this month, Korea earlier on this Thursday morning lowered its crisis level for COVID-19 as well. To take a listen.
오늘 중대본에서 코로나 위기 경보를 심각에서 경계로 조정을 하고 6월부터 본격 적용하기로 했습니다. 3년 4개월 만에 국민들께서 일상을 되찾으시게 돼서 기쁘게 생각합니다.
Now, for more on these latest developments, I have Professor Howard Lee at Seoul National University joining us live on the line. Professor Lee, it's been a while. Welcome back.
Thank you for having me back today.
I also have Professor Monica Gandhi at the University of California, San Francisco, live on the line as well. Professor Gandhi, it's a pleasure to have you back.
Thank you so much.
Right, Professor Lee, let's begin with your thoughts on the lowering of the national crisis level for COVID-19 here in Korea.
Well, as you said, Sunny, the crisis level for COVID-19 nationwide has been changed from serious to alert. That means almost all bans will be lifted in South Korea sooner or later, including the mandatory isolation policy for 7 days. This move has been prompted mainly by the WHO's recent declaration that the global emergency status for COVID-19 has been brought to an end. South Korea is certainly transitioning from pandemic to endemic for COVID-19. So I think the move announced today seems okay overall.
Right. Professor Lee, Korea's shift from pandemic to endemic comes amid a 3-month high in daily tallies this past Wednesday when authorities announced over 23,000 new infections over a span of 24 hours. How do you explain the surge in cases, and is it a source or a cause for concern, do you think?
That's confusing. But you know, daily tallies can be misleading because of day-to-day fluctuation. For example, the daily new cases were only 8,100 on the 8th day of May, which is a couple of days ago. And that's why we have to look at a more stable statistic, such as 7-day rolling average, which has remained stable under 15K for several weeks in a row. That said, I also want to emphasize that it is better this time not to look at the number of daily new cases any longer. That doesn't count as much as it used to, say a year ago. In addition, death rate by COVID-19 has been still very low. We are also in full control over the hospital bed in case of unexpected hikes. All in all, you don't need to worry too much about the daily jitter.
Right, I see. And Professor Gandhi, as Professor Lee mentioned, the World Health Organization has declared that COVID-19 is no longer a public health emergency of international concern. Now, some pundits, Professor Gandhi, believe this declaration itself is a surrender to the virus rather than a victory against it. What do you say?
You know, the problem with COVID-19 is it was never eradicable. And what I mean is there are different properties of pathogens that make it able to go away completely. And unfortunately, COVID-19 has none of those. It has animal reservoirs. 30 animals contain COVID-19. It has a long period of infectiousness. Its symptoms resemble other respiratory pathogens. And even though our vaccines are great at preventing severe disease, they don't prevent all infections. All of that put together means we actually could never completely get rid of COVID. What we had to do was get severe disease as low as possible. And what enabled that was increasing immunity in the population from vaccinations and from people having natural immunity. All of that led to a high degree of population immunity. The mortality from COVID-19 at this point in time, as of the time the WHO declared the end of the emergency, is the lowest that it's been since March of 2020. And that is what led the World Health Organization to say, it's pretty much where we are right now. It's as low as it could be in terms of severe disease. And we have to keep on fighting it, but we have to at some point declare the global health emergency over.
Right, and staying with that, Professor Gandhi, I believe the federal COVID-19 public health emergency ends on this Thursday. That would be May 11th there in the US as well. What does that mean for people there?
So here in the US, a lot of the measures and restrictions had already been lifted, but what had not been lifted was vaccination mandates for federal employees and for people entering the United States from other countries who weren't citizens. All of that will be lifted tomorrow. For example, someone can travel to the US tomorrow or day after tomorrow without showing their vaccine card. So that's really the main final restriction that will be lifted. The US also provides free vaccines and treatments even for uninsured patients, and those will actually continue until the federal supply runs out, so that people can get on insurance, hopefully, in the meantime.
Right, I see. Meanwhile, back here in Korea, Professor Lee, there is a bit of public concern over the lifting of mandatory isolation for COVID-19 patients, which will start from the first day of June, of course. How do you respond?
Well, unlike many people believe, mandatory isolation at this time, particularly in South Korea, will not be as effective as it used to be in the past in terms of stopping viral transmission. I, however, want to talk more about the societal impact of the removal of mandatory isolation measure. With this measure in effect, backed by law in the past, patients could take a rest at home once caught with the disease, and the medical care was mostly covered by the government. This will not be the case anymore in South Korea, meaning many newly infected patients have to go to work and they have to pay their own medical care out of pocket, which can be troubling to some people. This is something that we, as a society, have to put our efforts together, not to leave any single person behind without the needy healthcare support as we move along from a pandemic to an endemic.
Right, of course. Professor Gandhi, given the end in emergency status for COVID-19 there in the US later for this Thursday, I hear masks will become optional for most hospital patients, visitors, and even the staff. What is the response within the medical arena there regarding this particular reality?
You know, there's the most mixed reaction in the United States to what you just said. Masking in healthcare has been the last remnant of the mandatory masking in the United States. Masks in other places had been lifted. And in healthcare, it is being lifted in a variety of healthcare settings. Some people are very happy about that, saying that, you know, we need to smile at our patients, we need to see each other's faces. Some people are very disconcerted and don't feel ready for that. So there's a very mixed reaction, I would say. I think that it's going to be very optional for people, staff, and patients to mask. Right now, our hospital is still mandating masking, but it's going to take a while for everyone to get on the same page on that.
Right, I see. Professor Lee, meanwhile, do you foresee a rebound in COVID-19 infections in the near future? And if so, what do you recommend?
Well, I don't think we will see a rebound soon. However, what we need to closely watch and monitor is an observation that the number of new cases per population in South Korea is way larger than that in other countries, such as the United States, UK, and even Japan. Well, this may be because South Korea was still doing more tests per population than other countries. That's a possibility. At the same time, we should not forget that COVID is not gone yet. It is still with us, although its status has changed from pandemic to endemic. So we have to get vaccinated every year, probably, particularly those who are vulnerable to serious disease. Taken together, no worry, but careful monitoring and safe measure won't hurt either.
And Professor Gandhi, meanwhile, have governments, do you suppose, learned enough from COVID-19 to be ready to fight off future pandemics?
Well, it's a really good question, because what we need to prepare for now that we've had this pandemic is the possibility of new pandemics because of warming of the planet, because of our interactions with animals. We move so fast where we have extreme urbanization. All of that can lead to the possibility of a new pandemic. And I think we learned a lot. We learned a lot about rapid development of vaccines. We learned about developing antiviral treatments, and we learned about developing tests and wastewater surveillance. What we didn't learn is, unfortunately, there has been a reduction of trust in public health in many countries. I've been very impressed with South Korea's response to COVID-19, and what I perceive from afar, at least, that there seems to be very good trust in public health authorities in South Korea. Here in the US, we have about a 37% or lower trust in the CDC, which is our main public health agency. We have even lower trust in our local public health officials. That reduction of trust means that people are stopping giving vaccinations at times. For example, to their children, routine childhood vaccinations. We saw a measles outbreak in a state in the United States called Ohio. There was a big measles outbreak, of course, in Zimbabwe, in Mumbai. These are concerns that it's not just the disruptions of the pandemic that led to reduction in childhood vaccination rates, but a reduction in trust of public health. And I'm very concerned about where we are right now in 2023 about that reduction in trust, because if we have something else happen, we need to be able to trust and listen to public health authorities. So I think that's what we need to do as public health officials and medical people, is work on rebuilding trust.
Right, rebuild trust before working on the next pandemic then. Meanwhile, while COVID-19 is no longer a public health emergency of international concern, the World Health Organization has yet to decide on the fate of Mpox as the body meets for its 5th session to assess whether this outbreak still warrants the highest alert level, that is. While there have been reportedly notable declines in global tallies, some communities have been seeing a spike in cases as of late. For more on this reality, I turn back to our panel of experts. Professor Lee, let's begin then with your assessment of the spread of Mpox here on the local front.
Well, the case of Mpox is showing signs of spreading across the nation, as you mentioned. And we now have a total of 60 or so Mpox patients in South Korea. This is quite an increase since we had only 5 cases up until this March, all linked to some kind of overseas travel. What is both interesting and slightly worrisome is the fact that most cases we have seen since this March are something that were locally transmitted. That said, however, no need to panic, I guess, because many of them were found in sexually active males aged 20 to 40 who had been in some sort of inappropriate sexual contact. So if you stay out of that unusual practice, you are, I think, okay in most cases.
Professor Lee, then, so most of these community transmissions here in the country were as a result of sexual contact between some groups of people. Is that the only reason, do you suppose, behind the sudden spike in cases here in the country?
Sonny, I think that's an interesting question. Frankly, I don't know what has happened behind and caused the sudden increase in Mpox cases in South Korea. One theory, however, I can think of is that we could have probably paid more attention to Mpox right now than before, as we are freed from the concern that had occupied us for years. That is COVID-19, of course. This, I think, could have contributed to the increased number of Mpox cases recently, as we witnessed. In other words, not only physicians but patients have been more likely to report the possible cases, which resulted in an apparent increase in the number of Mpox cases.
Right, I see. Meanwhile, Professor Gandhi, I understand doctors in the US have warned about a comeback of Mpox cases across the nation. Could you tell us a bit more about that in detail?
Yes, so, Mpox hit the US earlier than South Korea and actually started in the UK, Europe, Canada, Australia, and then this global outbreak spread to the US, and we had a quite high number of cases in the summer of 2022. Then about the third week of August, cases started decreasing in the US and actually worldwide, and they were reaching very low levels. And then recently, just very recently, we've seen a resurgence of cases in the US and actually another one in France. The resurgence in the US has been reported from a Chicago-based clinic. This is a clinic that serves people living with HIV. Gay and bisexual men are the major risk group that's being affected by this Mpox global outbreak. And there's 9 cases so far, but what's a little concerning is that 6 of them were fully vaccinated. It takes 2 doses of the Jynneos vaccine to be called fully vaccinated here in the US. And so there's no severe disease. These are kind of lighter cases than we've seen before, but that is a concern because we actually thought vaccinations were going to be almost completely protective. We didn't know that for sure, though. We were basing that on smallpox vaccination being fully protective for smallpox. This is a cousin. Mpox is a cousin of smallpox. Smallpox, of course, has been eradicated for 43 years. Just 3 days ago, we celebrated 43rd year of eradication of smallpox. And it's the same vaccine for smallpox that we use for Mpox. But since there's never been a global outbreak of this size, we didn't know exactly how well the vaccine was going to work. And clearly there are breakthroughs that are possible on the vaccine.
I see. Professor Gandhi, then briefly speaking, would it be safe to assume that the latest rebound in cases there in the US is centered in the state of Chicago then?
Yes, it's in Chicago right now, and we're on alert in other cities, but we haven't yet seen outbreaks in other cities. There is an outbreak reported in France. So just 2 places in the world where there's a resurgence. It gives us some concern because Pride events and other big events are coming up this summer. But on the other hand, the cases are still very low compared to how high they were over the summer.
Right, I see. Professor Lee, could you tell us a bit more about how Mpox is transmitted and what are some of its broader symptoms?
Sure. Mpox can spread to anyone through close, personal, often skin-to-skin contact. That includes direct contact with Mpox rash and scabs from a person with Mpox, as well as contact with their saliva, upper respiratory secretions such as mucus, and areas around the genital organs. However, the risk is low for getting Mpox by touching objects, fabrics, and surfaces that have been used by someone with Mpox and not disinfected. That's reassuring. People with Mpox often get a rash that may be located on hands, feet, chest, face, mouth, near the genitals. And the rash will go through several stages, including scabs before healing. The rash can initially look like pimples or blisters and may be painful, or it can be itchy. Other symptoms are quite similar to those we see in common cold, such as fever, chills, swollen lymph nodes, muscle aches, backache, headache, and respiratory symptoms, including sore throat, nasal congestion, of course, and cough.
Right, I see. Professor Gandhi, you touched upon very briefly on the treatment procedure earlier on. Could you tell us a bit more about the prevention efforts then with regard to Mpox?
Yes, so Mpox is an orthopox virus related to smallpox, and really we didn't have a designated vaccine for Mpox. It's so closely related to smallpox that we just pulled out our smallpox vaccination stocks because many countries still had smallpox vaccine. For example, the US military is still vaccinated for smallpox, even though it's been eradicated. We ramped up production of the old smallpox vaccine. The safest one is called the Jynneos vaccine, and that is the vaccine that's used to prevent Mpox. Now, Mpox natural immunity probably has some protection. That's probably why the cases went down. But we really do encourage people who are at risk for Mpox to get vaccinated with 2 doses, 4 weeks apart, of the Jynneos vaccine. And in this country at least, and actually in most of this particular global outbreak, there was more association with gay and bisexual men, which just means that there was probably also sexual transmission of the virus, many more genital lesions, and genital lesions than we had seen in the endemic form of Mpox, which is found in West and Central Africa, and that's more associated with exposure to rodents. And so it's really prevention is the vaccine, and then treatment. If we have a very bad case, there is an antiviral being tried called tecovirimat for Mpox, but we saw the most severe cases of Mpox in people with advanced HIV infection, and that really is a group that we need to watch very closely and vaccinate.
Right, I see. And all this being said, Professor Lee, do you suppose that health authorities here in Korea should perhaps launch an awareness campaign against Mpox to better inform the public about the situation in the country?
That's another interesting question, Sunny. I think that might help, but the campaign should be more focused on the high-risk group rather than the general public, because as I said before, it is quite unlikely for a person to get caught with Mpox if he or she stays out of close physical contact with an Mpox patient. At the same time, the campaign should be carefully curated because it may stigmatize those with Mpox and those who are more prone to the infection.
Right. And Professor Gandhi, what are U.S. health authorities doing to perhaps curb the latest resurgence in Mpox cases there in the U.S.?
Yes, so essentially what they're doing, and really the U.S. campaign had been more again focused on gay and bisexual men and women living with HIV infection. So now what's going out to HIV clinics, I'm an HIV doctor as well as an infectious disease doctor, is the message that everyone who has HIV should be vaccinated. Make sure that those 2 doses every 4 weeks apart were obtained by anyone living with HIV in this country. And then gay and bisexual men, even if they do not have HIV, should all be vaccinated with 2 doses. So the message is really, just like with COVID-19, the message is vaccination.
Right. I suppose the wisdom then is prevention is better than cure. Professor Gandhi, as always, thank you very much for your time and your thoughts today. And Professor Lee, thank you so much for your insights.
Thank you.
Right, well, that ends our Thursday edition of Issues and Insiders. Thank you for watching. Do join us again same time tomorrow, that is Friday.